So now we have a new kind of novel treatment, which I've become a big fan of over the last year. And this is using multi-pulse technology, kind of coming at the totally other end of the spectrum of disease. And I think, many of us from our residencies and our fellowship trainings, do transscleral laser psychophotocoagulation. And I think, the common teaching was, you do this as a last resort on Friday at 5 before the eye blows up, And it's usually, don't do it on a good seeing eye. This is for the crummiest of crummy eyes. So once micropulse technology has allowed us to once again make the upsides of that procedure, which we'll talk about in a second. Once again, nothing in life is for free, but it basically has improved the safety profile significantly. So number one, you might not just do it on the end stage eyes. You can do it in some pretty good seeing eyes and relatively earlier disease, but you also can still do it on the really bad eyes. So we'll talk about the safety. We'll talk about why that is. It's a very straightforward procedure, and I'm a very tertiary glaucoma guy. I am the last stop on the train. People have had all this other stuff done. I do. They come to me to get tubes done. I do a lot of ECP. I do express mini shunts, trabeculectomies, MIGs, whatever, everything. So, but with all those procedures that require incisions, there's always downside, and some more than others. And our gold standard, trabeculectomy is, it's always 9 out of 10 of those go just swimmingly, and then you get number 10, and it's always like when I'm here, you start getting the phone calls on Saturday morning when you're in Hawaii, and about your post-op from a couple weeks ago. So this procedure, I think, is really something I think more and more about. And it's, number one, it's just good. It's for the patient's sake as well as mine. So it's a versatile procedure. It can be done both in the OR and in the office. It's fairly predictable, and it's titratable, and it's repeatable. The good thing, once again, is there's no incision. There's zero risk of infection. So if that's an issue. The other thing is you're not going to get the hypotony that you may get with more traditional procedures like trabeculectomy, and the discomfort that may come along from putting sutures on the eye. There's minimal external inflammation, and we'll talk about why that might be in terms of, once again, it goes back to the heating. The patient can go back to work the next day, which after glaucoma surgery is not usually something that I recommend. And minimal post-op medications. Basically, they're on steroids post-op. So in terms of efficacy, what to expect with the multi-pulse transscleral approach, we do have a fair amount of clinical data, and Paul Chu in Singapore has really been one of the early adopters or leaders. He probably started this 5 or 6 years ago when I first did some of this as well. And in Southeast Asia, the population is a lot of chronic angle or acute angle closure, which turns into chronic, tends to have a much higher IOP population. So in his population, IOP average was 40. So once again, these bad people that just kind of pop up, never had eye care before, were really super high at pressure. So he's done it, and on average gets the pressures down in the mid-20s, so a sizable gap. I think you'd say, well, for most of my patients, that's probably not what they are. So we have we actually have an ongoing multi-center U.S. study, which is looked at, I'd say, a more typical American population where the IOPs are 27.2. So patients usually on maximal medical therapy. The question is, they're going to get surgery of some port, whether it's a tube or trabeculectomy or this. And on average, the IOP lowering is down into the upper teens, which is, very appropriate. So the nice thing, what this says, and this is very true of my population, you have those bad people where you're just like, I want anything that's possibly can work to work, because I'm scared of these people. But on the other hand, it's like, these people aren't crashing and burning, but I want to make them better. And I want to try to think of the best thing in terms of downtime risk to the patient, and kind of the most effective way to do it without, number one, making them worse, or number two, causing a lot of stress on all our parts. So my personal experience kind of monitors both of those studies. Once again, I have some patients, neovascular patients, Friday 4, pressure's 50. We have to do something right now. On the other hand, I'd say the average patient that we treat is once again around 20. you know, on a couple of medications. But I found that in my population, the mean pressure was 25.5. The average got down to 15.7. To be fair, this is extremely a heterogeneous population. It tends to be very bimodal, like the high out of control people, and then the people who some drop is good. Just medications haven't done a good enough job. The nice thing is that we had no patients who had hypotony. And once again, when I teach the residents at Yale, I have this saying, it's like the only thing worse than high pressure is low pressure, because we can make high pressure go down. It's not that easy to make low pressure go up. And in this my series of my last 50 patients, 10 of the cases required retreatment. So I found about a 20% retreatment rate. And I tell the patients that good, because a lot of these people, they always say, you know, what's the next step? Because, you know, these days everybody's going on the internet, they see there's 10 different things that can be done. You know, they always want to know, like, what's the next step? And it's like, most often, if we tried this, we'll often, you know, there's always other things we can do, but retreatment is probably the simplest thing to do. So, typical patient was referred a few months ago, 65-year-old, had a CRVO, so not the greatest eye, but it was well treated. He got treated aggressively early. Vision's 20/80, the eye's nice and quiet, but he has kind of residual chronic angle closure glaucoma. The pressure's 40. He was taking 3 different medications as well as oral Diamox. And so we decided to treat him. He lived about an hour away. I'm in Connecticut, which is not the biggest state in the world, but, you know, so for these people, going 10 miles down the road is like a big deal. It's like, it's that New England mindset, which changes a little bit. So, you know, he didn't want to wait, you know, to be treated. So he came in on Friday. We treated him that day. For this procedure, I usually do apply a block because it's just faster and easier. It's possible not to, but it just makes it very fast, and, you know, and everybody has a different pain threshold. So I do a block, and his pressure was 10 with no pain or change in the vision. So once again, kind of in contrast to traditional transscleral psychophotocoagulation, where I tell everyone to expect a headache. A lot of times I give out, you know, Tylenol number 3, keep them on atropine for a week or so. These patients, we don't really have to do that. They might have a mild ache, I'd say similar to when I do ECP. So it tends to be maybe a little bit of ciliary spasm, but they don't come in the next day, you know, with their heads in their hand, much as we see with traditional psychophotocoagulation. And after 2 post-op visits, he had just had to come see me. I saw him like a week after, and then another couple weeks, he was stable at 10, and he went about his way. And he was functioning, he drove himself the next visit, and everything was good. And here he is. So once again, this is in the office. This is me wearing the purple glove. And so here we see the probe. So he's blocked. I just put a speculum in. And this is the probe, which we have up here. You can see it. And what you want to do, and once again, versus thinking about applying focal applications, is you really, once again, we're shooting this wavelength of light, near infrared, and it's targeting the ciliary body on the other side. So, and what you do is you think it's more kind of that laser trabeculoplasty mindset, where you're exposing as much of the ciliary body to the laser energy. You want to get absorption, and once again, it's cycling on and off, so you're not getting burns on any one specific thing. It's not like we're targeting ciliary processes, we're just making sweeps. So you typically sweep back and forth in one sector. I think this treatment was 90 seconds on the bottom part, and then you kind of flip around and do on the top part. And if anything, I err on the side of being a little bit back from the limbus. So it's a pretty boring treatment to watch, which once again, boring is good. But it's really just being kind of slow and steady, trying to taking about 10 seconds to get from 6 clock hours to the horizontal meridian is the way to go. But you can see the eye is nice and white. You know, it's not being traumatized. Like I said, if you don't block the patient, they can get a little achy during procedure. But this is all it is, you know, and afterwards I check to see if they can blink. If they can blink, you know, I don't patch them up. If they can't blink, then I tell them to keep the eye patch on until they feel themselves blinking again. And so really a relatively atraumatic thing to do, that versus the alternative. This patient was get a tube. Yeah, that was the other thing. Next case, a 78-year-old woman with pseudoexfoliation in her right eye. IOP is 38 on 3 meds. She's status post-cataract surgery. And, not unfamiliar in exfoliation glaucoma. Her pressure just started going out of control. It was well documented, always in the upper teens. And then one day, 1 week, it's just started going up. So, and her visual acuity is good. So 20/40 in that eye. She had a lot of visual field loss, so this was never going to be a 20/20 eye. Where the other eye was quite good. Once again, not unheard of with an exfoliation patient. So we offered the options, trabeculectomy to get her lower. We talked about doing a tube. She wasn't in the best of health, and so we made the decision to try this. I thought it would be the least traumatic thing. We didn't have to worry about getting her eye pressure too low, because I thought, I find that patients, once they get up near 80 or above 80, these are the choroidal people. It's very rare to get choroidals in the younger population, but this older population I find has a much higher risk, especially when we're dropping her pressure from up around 40, down to 10. So I thought this was the safest thing for her to do. So we treated, very similar as we saw in that video just a second ago, got her pressure down to 6 to 10 millimeters of mercury in the first couple weeks. Just maintained her on Durezol 4 times a day, which is what I prefer to do in all of these patients. And her final IOP at 3 weeks was 15 millimeters off of, once again, a bunch of medications. And her visual acuity, in the low period, it went down a little bit, but she was back at her baseline after a few weeks. So relatively atraumatic, with only about 3 or 4 postoperative visits. And once again, she was largely controlled after this procedure.
Does it matter whether they're phakic or aphakic?
No. You always worry about anybody who's phakic. You can progress their cataract, which... once again, not to be a mercenary, but I don't always look at that as like the worst thing in the world. Younger, like if someone's 20, that's something you have to consider, and I've done it in 20-year-olds, but anybody over 40, say la vie, right?
Dramatically make a difference?
It depends. I think that, there's trauma like with vitreous in the eye, and there's trauma with, the lens moving around all over the place. I find this, and they tend to be a younger population as well. I find this a very good procedure to do in that population, because I find that they tend to scar a lot. I think that when you have trauma, your eye is always kind of undergoing kind of chronic inflammation, as you were alluding to. So I think it's a nice, safe thing to do. And once again, the people that are problems with is these big drops in pressure, and I find the trauma people tend to be, pressure is 40, whatever. So I think the eye tends to be much more stable, especially in I worry the second most population besides an older population is post-vitrectomized eyes. I get very skittish when people have had, all the vitreous removed, because once again, if they have any hypotony, they're very high risk for having, a choroidal effusion. So the point of this slide here, this is UBMs of a patient pre and post micropulse. And here's the ciliary body. And the important thing here is that it doesn't look different. That's basically a takeaway point. When you start comparing anatomy to anatomy, here's the ciliary body, iris anatomy, back here the choroid. You can't really tell what the treatment zone is. This is an area of the treatment zone. I think there's a little increased inflammation here, but the architecture is intact versus, our old photos that we did back in the 90s. This would be gone. It basically, blows up the ciliary process, because the name of the game here is slow energy absorption by ciliary body / the uvea versus focal high energy kind of blowing things up. And once again, you're not getting a lot of focal heating. Focal heating makes things boil, and you can see it when you do transscleral psychophotocoagulation. If people have a lot of pigment on their surface, you can get a burn even on the surface of the eye. But the pops that we get with the traditional transscleral approach are over treatment and bad. There's architectural disruption, and that equals inflammation. With this procedure, you never hear a pop, once again, which is in some ways a little bit frustrating, but you're always sub-threshold of any damage like that. You're targeting the ciliary epithelium, and probably some of the vascular. And so it really appears when they've done these latex bead studies, that besides the aqueous reduction from targeting the ciliary epithelium, you also seem to have some increase in uveal scleral outflow. And that's probably because you're targeting things with pigment or color in them, so blood, pigment, melanin. but you're not coagulating it. So once again, coagulation shuts off any outflow. So there's evidence that there's also an increase in uveoscleral outflow, which actually makes sense. And once again, just to compare and contrast, the older technology, with the downsides and why we reserved it for the almost blind eye, is going back to this heating effect. And when you measure the temperature, this was a study done in air, so it's probably the worst case scenario, but it's representative and gets to the point here that when you have a traditional transscleral probe and you're just push the pedal down and it's continuous energy delivery for 2 seconds or whatever it is, there's a lot of heating that takes place. In air, it's around 550 degrees. In a water situation, it's lower, but the point is you can boil water in a very short period of time, which is not the best thing for your eye. So just to wrap it up here, and we're in this era of MIGS, and glaucoma has actually gotten more interesting, regardless of what our cataract colleagues think. But MP3 is really kind of crossing the lines. Once again, it's taking a similar technology and what we're used to in terms of our thinking. Like this is the last ditch, after a tube, and only do it in hand motion eyes or LP eyes or whatever, and really moving into people with good vision. And I think it's in terms of work around the surgery, it tends to be a very relatively quick procedure to do. It just takes working time is about 2 to 3 minutes. So that's nice. The patients tend to be very comfortable. I mean, to be fair, if I put sutures in someone's eye, they're not going to be as comfortable as if I do this. And the risk of hypotony, I think, is much lower. So I think in terms of alternative treatments, and a lot of people come and say, I don't want a hole in my eye. I get that's probably one of my first referral pattern is my eye pressure is way too high. Second one is I don't want a hole in my eye. And so, once again, we go through the options. We have MIGS, we have ECP, we have this, and I think this is a reasonable option for many patients. I wouldn't say, like, patient walks in and is diagnosed with glaucoma, this is the first thing I would do. I don't think it's that, because there is some invasiveness associated with it versus medications, for instance, or MLT, for instance. But that said, when you're starting to think about the next step up, in terms of a surgical intervention, I think it's entered the consideration set, and it's all because of the improved safety profile. That's the biggest selling point here, and the ability to get low, because MIGS are very attractive. The problem with MIGS is they don't get the eye pressure that low. For not a mild patient, great, good. For a real glaucoma patient or patient with moderate damage, I'm thinking, am I doing a trabeculectomy express, a tube? Those types of things, or this, and I think it bears considering, and I'm increasingly more comfortable doing it. And after I have a complications with one of the other procedures, like a wound leak or something, it's like, well, I really wish I did the MP3.